Dr. Yu-Tsueng Liu, and he's going to talk us about clinical and laboratory analysis in a work that was done jointly with Mozambique and Zimbabwe. Thank you.
Good morning. I'm honored to have the chance to present our international study in Zimbabwe and Mozambique. So the topic is about a cancer called ocular surface squamous neoplasia. So it's an umbrella term for a range of a tumor. And this disease has not been recognized, did not attract attention before the HIV pandemic in Africa. So this disease actually has a very interesting biology. It's the abbreviation is OSSN. And it's a tumor on the surface of the eye, so it's including the conjunctiva and the cornea. And it has been another name called conjunctiva squamous cell carcinoma. And it actually has an interesting biology because the tumor usually starts from the limbus area, which is the transition between conjunctiva and the cornea. And it's the disease initially from here, and if it is not treated, it can grow into a big tumor, occupy the whole orbital. So this is definitely an HIV-associated malignancy. So from the world map, you can see that right now the disease concentration is in Africa area. And also there's another characteristic is that it actually has associated with the area has a lot of sunshine. So there's a sporadic case all over the world. And in this case, you can see in Uganda that the incidence of the OSSN actually is parallel with the onset of the HIV. So that's actually, this is just one example. There's a lot of evidence suggests that this, just based on epidemiology study, this is definitely an HIV-associated malignancy. So this OSSN before the Africa HIV pandemic, it actually is not been, I don't know if there's any report in the HIV patient in the United States. So it actually definitely is a multiple factor etiology. So it's one important factor is UV light exposure. And so currently there's kind of two patterns. The HIV related is happening in Africa. And that's before the HIV pandemic, the report actually is most predominant in Caucasian male patient. And that's a lot of our report try to associate this disease with the HPV and maybe other virus. And I will talk about this actually is one of the focus of my study. And also because the initiation site is a limbus transitional zone. So actually there's a kind of stem cell hypothesis there. But today I'm not going to this direction. So this is our cohort in Zimbabwe and Mozambique. We have 50 cases in Zimbabwe and 117 in Mozambique. And my colleague, Dr. Jonathan Lin, he also did a study in San Diego. So I used that to compare. And obviously you can see that the median age, I mean the HIV positive rate is about 80 to 90% in Africa. And you can see only 10% in San Diego. And the median age in the Africa is much younger than the patient in San Diego. Oh, sorry. So that the CD4 count, you can see that those patients are lower than 200. So this is definitely an AIDS-related disease. So this actually is before our study has been in the literature. So it's our cohort actually is a representation of the previous study also. You can see that in the United States and Australia, that's not HIV associated. The patient is older age. And actually the male and the female ratio it's in the HIV unrelated actually is male dominant. So the disease actually is interesting in terms of compared to cervical cancer. And it actually the disease has a historical term called conjunctival intraepithelial neoplasia. This is kind of parallel with the cervical cancer nomenclature. And the starting site is the nimbus transitional zone. So let's actually see that if I can remind you about the cervical cancer, you can start from the transitional zone here, and the disease progression is from CIN1 to CIN3, and then the carcinoma in situ and the invasive disease. So the nomenclature is actually similar, and they all start with C, so just look at the same. So in cervical cancer study, because the cervical cancer is almost 100% associated with HPV, and that's from many years of study, I find that the pathophysiology of the disease. So that's one marker, P16, actually has been used a lot in the cervical cancer field to represent is the HPV infection. So this work actually started from almost 20 years ago. I mean, the work actually shown in the 20 years ago in Peter Howley's group. They actually show that they show the HPV infection cause P16 overexpression. And the reason for that is because there's a viral oncogene called E7. The E7 will inactivate cellular tumor suppressor gene called RB, and it release a transcription factor called E2F. The E2F actually, when the E2F activates, the cell will go into a cell cycle and start to proliferate. But in the normal cell, actually there's a mechanism to stop this process, to let it go back. So the process actually induces another tumor suppressor gene called P16. So the P16 will go back to kind of inhibit inactivate the RB, so kind of stop the process so they can be regulated. But when you have a virus infection, you have E7 just continuous block the RB, then the P16 is overexpressed, and the RB cannot suppress. So the P16 is always high. So in this diagram actually also show that it's not just the virus infection that causes P16 overexpression. The RB inactivation will cause the P16 inactivation. So in the case here, in Peter Howley's study, there's two cervical cancer cell lines. They are HPV negative, but they are RB mutated. So the P16 is also high. This actually, I spent time on this because it's relevant to our preliminary study in the sample. So we did a P16 RNA Tegman real-time PCR to analyze the E6 P16 expression in the tumor sample. So actually, we don't have a really standard tool. We have an appropriate negative control here. And we don't have a really positive control to show that it's really positive. We used a cell line called HeLa cell to show that the label of the expression. So we use HeLa cell expression label as cutoff to determine which, can I call it P16 overexpressed or not. But I believe that our sample because we use a HeLa cell to do the cutoff, I think we have more higher percentage of the P16 overexpression. So the result actually in our case is about 30% of them are P16 overexpression. But my colleague in San Diego has got a very striking result. It's almost 100% P16 overexpression. It's kind of curious about what's happened here. But as I show you that the cervical cancer, usually P16 overexpression is due to HPV infection. But in our case, we use a real-time PCR to detect. It's actually, we got nothing. We don't see any HPV positive. And interestingly, in San Diego case, they picked the most highly expressed P16 sample to do in situ hybridization, and they also get 0. So, so this is just the beginning of our study. We definitely have to do more and analyze more. But this area actually, OSSN with HPV association actually is very controversial in this field. You probably cannot see it, but in summary, that's our study. The positive rate is from 0% to 100%. And the HPV type has 16, 18, and other cutaneous and all over the place. So this definitely is an area that needs to be resolved. So we're currently just starting to doing the laboratory analysis for the sample from Zimbabwe and Mozambique, and also with our collaborator with San Diego. So our conclusion here is that the patient with OSSN are mainly HIV positive with low CD4 count. And it is unlikely that all the OSN are associated with HPV 16 and 18. And a viral etiology cannot be ruled out because due to the P16 overexpression in those samples. So the viral etiology could be HPV and it could be other virus also. So for example, polyomavirus T antigen also causes P16 overexpression. And if that's not viral cause, it probably is due to the cellular change. For example, RB inactivation. So we cannot rule out any possibility. So this is our collaborator in this study, and it's supported by the pilot HIV malignancy pilot project UCSD. Thank you.
Thank you, Dr. Liu. Now we are open for discussions.
Very nice presentation, YT. If you look at the demography of the patients, they seem to be patients with advanced immunosuppression associated with HIV, which is often associated with other virally driven malignancies. If it's not HPV, what else would you look for in the haystack? So
the virus-associated malignancy actually is just a couple of the viruses currently reported. So one of the candidates, because we are looking for P16 overexpression, so that must have a viral oncogen can inactivate RB. So one of the candidates, polyomavirus. So I was thinking about doing the merkel cell carcinoma virus. This is another very rare disease, but it's been shown by Patrick Moore. It's the bona fide it's a virus-associated cancer. So we actually right now is analyzing the association. And the next step, if we don't find anything, the next step we probably have to do whole genome sequencing.
So YT, how specific is your type 16 probe, and wouldn't it be, if it is, wouldn't it be reasonable to look at the other 60, 80, 100 HPVs, or a less specific papilloma probe, which, as with cervical cancer, could be etiologies? Yeah, so I actually, in other field, for example, head and neck cancer, the HPV association, they actually think that, at least the one paper I read, they actually think that P16 is it's kind of P16 is a functional study because it actually had related to the cell cycle. In our study, actually just try to look at the HPV DNA in the sample. So HPV present in the sample doesn't mean that the HPV caused the disease. So in my real-time PCR, I actually just detect E6 and E7 instead of looking for the other region. So that's that might be some dissociation between my study and others, because other study mostly just looking for HPV DNA. In terms of other study, other virus, we can use the broad spectrum PCR primer to detect the other disease. But I think that this day, because the next-gen sequence is so popular, so if I don't find any solid evidence here, I'll probably go next step for the whole genome sequencing.
So why this OSNN is prevalent in USA? Is there a general reason for that? Like you show that map and you see the maximum population is in USA, but not the other part of the world. So yeah, is there something to do with the UV how to differentiate with the UV specific or HIV specific?
So I think in Africa, I probably have to, it's not just HIV, it also has to be UV specific. Because this, I didn't get into the literature, but in the HIV patient in the United States, I don't think I recall anybody report that the high incident OSSN in the United States. So that the researcher pay attention to that because it's just happening in Africa HIV pandemic. And that one of my collaborators, he said that in 1990, he didn't really pay attention to this disease. After 1990, he started to see a lot, not a lot. It just kind of started to pay attention to this disease. So that's multifactor. A lot of the cancer, it's not just one, usually not caused by one factor, it's multiple factors. So I think that UV irradiation probably is also an important one. I have to have both. The sporadic case, the problem is all due to UV.
Thank you. We take one more person.
It's a nice talk. Thank you for that. As I was listening, I had this association or a link to Kaposi sarcoma, which is another kind of HIV-associated malignancy, and it's associated with severe immunosuppression in HIV patients. And in the case of Kaposi sarcoma, I guess it is now pretty established that a certain role is played by the chemokine system. So the virus, Kaposi sarcoma virus, which is a herpes virus family representative, encodes chemokine receptors, and it encodes chemokines that interfere with human chemokine receptor signaling system to promote viral replicative advantage. And so my question is essentially, do you know anything about the role of that system in this malignancy possibly, and is there any way to screen and detect it?
I'm not aware of the people who have done this study, but the treatment actually, one of the treatments used interferon to treat this disease. So they might have some association with the chemokine. I don't have any direct evidence.